Hi folks, today we are going to see tackling a diabetic membrane. This appears to be a very flat membrane. Forgive me for the blooming in the video. I'm trying to find a plane all throughout the membrane, and there I find one. There's a small iatrogenic break, if you notice, down there with some schlering oozing out through it. I go in with my cutter, try to cut the membrane one bit at a time between the plane, releasing all the connections and tags of the membrane with the retina. The membrane appears to be a flat one. Usually there is a clear plane between the membrane and the retina with multiple point attachments or flat attachments, and these attachments are pulled up to cause traction to the retina. But very often when you have such flat membranes, there are multiple other membranes beneath them as well. We will see that as we proceed with the video. There's a little blooming, but I'm working in the plane between the membrane and the retina. I'm somewhere near the disc. And that's the edge, the nasal side. And I thought that's it. The membrane has to be severed superior nasal to the disc, and we are done. I'm trying to go in with the blunt spatula, and that's where I find that it's not just a small attachment. The entire posterior hyaloid is adherent nasally, and that needs to be separated from the retina. So now I'm beneath the attached hyaloid in the plane and trying to lift it up with the cutter and free it from the retina and cut it one at a time. Again, the blunt spatula to dissect a little further, advance the plane as much possible, taking care not to damage the retina. Very often you find small twigs of new blood vessels or new vascular fronts attached to the posterior hyaloid, and that's how the disease is. This one area where I see a nasal large trunk into the membrane. Eating up the separated membrane over the disc. I went towards the connection near the vessel and I thought it would bleed. So I withdrew the cutter, used the cautery to cauterize the major trunk, and then sever the membrane there, which is going to inevitably eat up the blood vessel. It's a small ooze which is cauterized again. It's very important to clear the field whenever there is a ooze, because later in the surgery it obscures the view. Now this is a bent 24 gauge needle, a very subtle bend in the tip which easily goes to the 23 gauge port and helps in a sharp dissection between the membrane, which a blunt spatula cannot do. So it separates the membrane, lifts up the membrane, and also simultaneously cuts the small twigs. Now here we see the hyaloid again adherent to the retina and getting separated. The purpose is to lift the posterior hyaloid, makes linear breaks in it. How easily it helps separate the hyaloid. The bevel is towards the retina, the sharp edge is towards the membrane. Eating up the separated membrane again with the cutter. And now in ferronasally, the hyaloid needs to be separated. So we go back again on the wide field lens to tackle the hyaloid and reduce the anterior posterior traction so that we don't have any peripheral breaks. In the meanwhile, to have oozing from the severed small twigs, clearing the heme is very important because it hampers the view of your membrane dissection and is the most common reason for iatrogenic breaks. Again with the blunt spatula, trying to find a membrane. Appears to be quite adherent. When such adherent membranes are dealt with, there is usually a large neovascular front in it. Cutting off or bisecting the membrane, and there's the front which is bleeding. Need to cauterize the front as soon as possible so that we don't have an obscuration of the field. It is indeed time consuming to intermittently clear off the bleeding, the clots. These clots form a membrane over the retina again, which consume more time to get released and peeled off. Blunt spatula sometimes comes handy when we are dealing with larger neovascular fronts. Some more cauterization of the fibrous vascular proliferative lesion at the disc. Using the 24 gauge needle with the bent at the tip to further dissect the membrane. The aim is to dissect and excise as much as possible. Sometimes you may have to just trim the polyp at the disc and leave it there, but it's good to excise it as much as possible. Just a nudge with the forceps so that it gives a good peel. That's how the heme forms a thick layer on the retina, which is very difficult to remove sometimes and causes iatrogenic damage most of the time. One has to be very careful while peeling such membranes. Patience is a virtue when we are dealing with such membranes, and it takes time, but it's quite satisfying. To cut these membranes and achieve as much anatomical success that is possible. These membranes also indicate the ischemic status of the retina and the optic nerve head. So the small fibrous membranes, thready like, which are rarely visible when there is heme. So clearing up the heme again, a good view is imperative in such cases. This patient has undergone the cataract surgery followed by vitrectomy. Using the forceps again, trying to peel it. Sometimes you cannot avoid desperation, but yeah, have to correct it again, go back slow, take a step back, wait, reassess. There's so much of silence inside the cavity and your mind, and sometimes it's very important for this focused processes, and that's what we want to achieve. Thank you.